This
Yeah.
conference will now be recorded.
Okay, so today we will be discussing this 2017 January talk, surgical management of bowel obstruction and gynecological malignancies. Okay, this talk is actually goes in very detail regarding the bowel obstruction during cancers. So I have tried to make it as simpler as possible. So we'll discuss. Please mute your mics, please. So most commonly, bowel obstruction is associated with ovarian cancer, and the main subtype is epithelial. So this is the question. This is the SBA asked in this TOG also, and it is mostly associated with recurrent gynecological cancers. So most common type of cancer associated with it is epithelial ovarian cancer, and it is most commonly associated with recurrent ovarian cancer, recurrent gynecological cancers. So up to 50% of women with epithelial ovarian cancer, they have been reported to develop bowel obstruction. Okay, so almost as much as 50% women with epithelial ovarian cancer, they develop bowel obstruction. Now, ovarian cancer is the sixth most common cause of cancer in women and fifth most common cause of cancer-related death in women. Bowel obstruction, it is often a clinical manifestation of relapse disease and it is associated with poor prognosis. So it is a recurrent disease and poor prognosis. And complications of bowel obstruction is the main cause of death in women with epithelial ovarian cancer. Now, what is the pathophysiology of bowel obstruction in gynecological malignancies? So one is widespread carcinomatosis, that is either primary or recurrent disease, which will cause intestinal motility dysfunction. So widespread carcinomatosis is one factor. Another thing is either intra-abdominal or loco-regional recurrences. It will cause either extrinsic or extraluminal occlusion. Okay, so it is a bowel occlusion by recurrence of the disease. Retroperitoneal disease, which will involve meandric plexuses and adhesions. So another thing is retroperitoneal disease, and most of the time it is not a single site obstruction. So most of the time surgical cases you will see it is a single site is involved for bowel obstruction, but in case of gynecological cancer it is a multiple site. More than one anatomical site is involved in the obstruction. So sometimes this bowel obstruction can present as an initial presentation of gynecological malignancies. So incidence of such initial presentation is around 8 to 30%. Now another thing what they have observed is surgery for bowel obstruction. It is performed less often with primary disease. That is in 14% cases only it is performed with primary disease, while recurrent disease the surgery incidence is around 34%. And they have pointed out that if the woman develops bowel obstruction as an initial presentation, then it is a shorter progression-free survival and also less overall survival. And what are the contributing factors for the shorter survival is because what happens when this patient presents with bowel obstruction as an initial presentation? So most probably they are less likely to undergo optimal or complete cytoreductive surgery. That means removing all disease up to less than 1 centimeter in diameter or no visible residual disease. So less optimal, there are very less chances that they will undergo a complete or optimal cytoreductive surgery. Why? Because the basic objective to treat is the bowel obstruction. Okay, so it is not surgery is not taken for the malignancy itself, but it is taken for obstruction. Usually the women are often unwell and they need urgent and or emergency surgery. And most of the time these women are operated by general surgeon because they come with intestinal obstruction. They will operated by general surgeons, and during the course of surgery they will find out that it is because of malignancy. So that these are the basic reason that there are less chances that they will go undergo optimal cytoreductive surgeries. And also there will be presence of micrometastasis in bowel mesenteric lymph nodes. So it can be also factor that is contributing to the poor outcome. So micrometastasis will be there in the bowel lymph nodes. Now, how you're going to diagnose this intestinal obstruction? So nausea and vomiting, it is a predominant symptom by proximal intestinal obstruction. So when the woman have proximal intestinal obstruction, common symptoms are nausea, vomiting. While for distal obstruction, the common symptoms are abdominal distension and abdominal pain. Usually it is a spasmodic pain. So spasmodic pain plus abdominal distension are common features for distal obstruction. While absolute constipation, it is a classic feature of total obstruction. So absolute constipation, it is a classic feature of total obstruction, while sometimes watery or loose stools. So it is a mostly, it will present typical of partial or intermittent obstruction. So watery stools, it will be because of partial or intermittent obstruction. Usually these bowel obstruction symptoms are chronic and usually with a history of prior hospital admissions and conservative management. Okay, so most probably there will be some resolution with conservative management. So these symptoms will present as a chronic bowel obstruction symptoms. So the diagnosis, apart from these clinical symptoms, the diagnosis by plain abdominal X-ray, which will demonstrate air fluid levels. CT can be useful in evaluating obstruction site, also documenting the disease pattern. But usually the CT use is limited because contrast agents cannot be given. Because of obstruction, oral contrast agent cannot be given. And also usually the small disease, less than 1 centimeter, peritoneal disease or plaques, they cannot be detected. Usually the all women, so the woman who will have a history, prior history of ovarian cancer and they come with intestinal obstruction, usually they have a recurrent disease. So almost all women of ovarian cancer with history of ovarian cancer and when they come with bowel obstruction, mostly they will have a recurrent disease. Also, you have to see whether they have received any chemotherapy and especially this biological therapy, that is bevacizumab. If they have received this bevacizumab, you should be more careful if they have received it in preceding 6 weeks because it has this anti-angiogenic functions and it impairs with wound healing. So if they have received bevacizumab, you should be very careful whether to do the surgical management for this patient or not because the wound healing will be impaired. So now this is the flow chart given in the talk. I have just fragmented it so that you will understand it better. So here they have given the diagnosis. So symptoms are either nausea and vomiting, which will suggest proximal, abdominal distension or pain. It will be suggest distal obstruction, altered bowel habits and dehydration. It is because of the nausea and vomiting. Also signs are distended abdomen, tenderness or peritonitis, high-pitched or absent bowel sounds. On imaging, plain abdominal X-ray, you will find out fluid levels, dilated bowel, and fecal loading. CT abdomen pelvis also you can do to see the disease site. So immediate management, investigations you will do, that is full blood count, urine, per abdominal examination, plus minus CT. You will start IV access. You will rehydrate the patient with at least 2 to 2.5 liter of fluid, which is most probably normal saline plus 5% dextrose. Nasogastric tube if vomiting is present, and you have to strictly maintain the fluid balance chart. This becomes the immediate management. Now, symptomatic management. Basically, this management is divided into immediate management, symptomatic management, and definitive management. So, symptomatic management, what you have to treat is first is pain. So, you have to see what the patient is receiving, okay, for this pain. And you have to remember that you have to change the route of drug administration. So, oral route is unreliable because of vomiting and unknown rates of absorption. So, drug should be administered by alternative route. So either subcutaneous, intravenous, transdermal, rectal, sublingual, whatever is the route, but not by oral route. So for pain, the most commonly thing or most best thing for cancer pain is it is a morphine. Okay, and as a spasmodic, antispasmodic, you can also give iosine butyl bromide. So this is the two things that you are going to give for analgesia. As antiemetics, you will be giving cyclizine or levomethazine or haloperidol. So it is continuous subcutaneous infusion. You have to avoid metoclopramide. Okay. For antiemetic, you have to avoid metoclopramide. Also, as a laxative, you should not give stimulants, but you can give stool softeners, that is Milpar or Docusate. Steroids, if the patient is not for surgical management, you should start her on steroids. And the dose is 8 milligram twice daily IV for at least 5 to 7 days, and then maintenance dose, okay? Or it is in the tapering drug regimen until it is stopped. So morphine sulfate, as I told you, it is the opioid of choice for cancer-related pain. Tiosin bromide, it is effective at reducing the unpleasant symptoms associated with intestinal colic. So it is usually antispasmodic. Now, another thing of what you can give is octreotide. So octreotide is a somatostatin analog. It reduces the gastric acid secretions and bile acid. It increases mucus production. It slows intestinal mobility and reduce the bowel wall edema. So, which will also help in the nasogastric tube withdrawal. Now, steroids, why you will be using? Because of its antiemetic properties and reduction in bowel wall edema. Because this bowel wall edema, it develops with bowel obstruction, and steroids will help to relieve it. Also, there is evidence that when corticosteroid is given intravenously, it will result in resolution of bowel obstruction, and the side effects will be low. Okay, and it can be effective in controlling the symptoms of bowel obstruction. So when the patient is not for surgical management, you should start them on steroids to see whether it resolves this bowel obstruction. Now, regarding definitive management, you have to either go for surgical or medical management. So I will come to that, which patient surgical management is preferred and which patient medical management is preferred. So if the bowel obstruction is not resolved with this conservative management, you have to think of surgical management. You have to contact gynecological surgeons, review within 24 hours along with CT scanning. Surgical decision will depend on whether it is a first or recurrent episode, because for recurrent episode, surgery will not be that effective depending upon the obstruction sites, whether it is a single site or multiple site. Because for multiple site also, the surgery will not be that useful. Also depending upon the disease site, whether this patient has previously received any treatment, any surgery or any radiotherapy, or also depending upon the bedside review. So if the surgical management is there, the patient will go for definitive surgical management. If the patient is not fit for surgical management, again she will be on the conservative management. Now, if the bowel obstruction, it responds to this conservative management, you have to see that whether it is a nasogastric tube output is decreasing or not, and then you can commence per oral, and you have to start with very small volume first, that is 10 ml per hour, and then you can increase like 30 ml per hour, 60 ml per hour. Okay, you have to start with first free fluids, then low residue diet, and it depends upon all the dietitian advice. Also, you have to think of chemotherapy also. If the patient has not received chemotherapy previously, sometimes the chemotherapy will also resolve this bowel obstruction. And here you have to see which chemotherapy, if she has received previously. As I told you, if she has received bevacizumab, she may not be a candidate for surgical management. Also, you have to see whether if she has received any previous chemotherapy, what was the disease-free interval. If the disease-free interval is more, you can again start with the chemotherapy. So it depends upon whether the patient, and it depends basically on the multidisciplinary team management. Okay, it is not a single decision, but it depends upon the multidisciplinary team management. So if the conservative management, it does not relieve the symptoms, surgery should be considered. Now, what are the dilemmas that are faced with when to take the decision for the surgery? So because it is associated with significant mortality and morbidity. Also, risk of failure is there to achieve the palliative goal. Also, short-term palliation also may not be achieved with the surgery. No consensus on the definition of successful surgical palliation. Few guidelines are available and limited quality of life data. Because as I told you, this bowel obstruction with this ovarian cancer, it is associated with very poor prognosis. So very less data and few guidelines are available. So again, it is a dilemmatic decision. Now, what are the surgical options are available? So either you can just open or close, because you can't do anything. Sometimes you can just open and close the abdomen. Sometimes placement of gastrostomy tube can be possible. Bowel resection, if it is a single site, are amenable to resection. Anastomosis, as I told you, if it is a single site only, you can do resection and anastomosis. Otherwise, you have to do the bypass procedure like diverting stoma. If it is a multiple site distal obstruction, you can just give a diverting stoma. Okay. Segmental resection, or usually typically a segment of colon is removed where the mucus fistula is formed. Okay, so as multiple sites of recurrent disease is typical cause of obstruction, usually diverting stoma is placed and the cancer sites causing the obstructions are not resected. So this is the most commonly performed surgery because it involves multiple sites. If there is only one or few disease sites, you can do complete resection. And it can be feasible and appropriate without necessitating dependency on total parental nutrition. Now, the post-operative mortality associated with this surgery is from 12 to 25%, and morbidity will be significant, at least around 50%. Reobstruction rate, they are as high as 26.5% at the intervals of 8 points. So mean interval for developing reobstruction is around 8 months. Also, this outcome of surgery, it depends upon the case selection, and the presence of significant ascites is usually it is a poor prognostic factor. With successful palliation is less than 20%. So the unsuccessful this surgery is associated with when there is absence of any abdominopelvic mass, when there is presence of ascites, when there are multiple levels of obstruction, and when there is weight loss more than 9 kgs. Sorry. So these are all the factors which are associated with unsuccessful surgical outcome. Now, when the bowel obstruction develops with previous radiotherapy, okay. So if the bowel obstruction develops with previous radiotherapy, as I told you, it is more responsive to surgical management because here the underlying cause is usually not the recurrent cancer, but it is because of radiation fibrosis. Okay, so there will be more likely to be a single obstruction site, and usually it is a terminal ileum. Okay, so the cause will be not a recurrent cancer. The site will be most probably single site, terminal ileum. So if you take a earlier surgery, then it will be more useful. Also because it is more prone to the ischemic damage. This irradiated bowel is more prone to ischemic damage and perforation. So if the bowel obstruction develops with previous radiotherapy patient, the surgery is the major stay of treatment and it should be done earlier. And now here, when the bowel obstruction develops with previous radiotherapy patient, the cause is mostly either cervix or uterine malignancy and not ovarian malignancy, because in ovarian malignancy, radiotherapy is not used. So when the patient has received previous radiotherapy, such a question can come. If the patient has received previous radiotherapy, the cause of obstruction will be either cervix or uterus, but not the ovarian cancer. Now here, if you perform surgery also, the complication and leakage from the anastomosis is more common, okay, than that of the non-radiotherapy patients. Now, if the patient is not fit for surgery and not responsive to conservative management also, then what are the alternative treatment options? So alternative treatment options can be explored where there is a poor performance status. Okay, so poor performance status means there is a definition that is regarding performance status where they have taken into consideration whether the patient, how is the patient activity status and all this. So depending upon that, if the patient has poor performance status, you can go for alternative treatment option. Extensive carcinomatosis with multiple bowel obstruction sites and ascites. So in all these cases, you can think of alternative options. And now what are these alternative options is either radiologic or endoscopic placement of self-expanding metallic stents or palliative gastrostomy tubes. Now they have given something in detail regarding these gastrostomy tubes, palliative or ventive gastrostomy tubes. So these tubes will enable the patient to remain at home in familiar surrounding with her family. Approximately 90% of women, they will tolerate the oral intake. Also, soft diet is tolerated in around 25%. Also, most of these gastrotomy tubes are placed in when the patient is in incurable phase of disease. Okay, so where the median survival is less than 6 weeks and 90% survival rate is less than 6 months only. So it is usually performed in terminally ill patients. It can be placed through small incision or it can be placed either through endoscopically or radiologically also. But wider bore tubes, they require surgical incision. Also, the presence of upper abdomen disease. So, upper abdominal disease is a relative contraindication for placement of these gastrotomy tubes. So, this is a somewhat a newer thing that you can do in the palliation as a palliation only, not a treatment option, but it is a palliation where the survival is very less. Now, what is the post-operative survival in case of bowel obstruction? So, as I told you, the mortality is very high, around 25%. So, median post-operative survival is 3 to 6.8 months. And usually prolonged survival, it can be a result of more effective post-operative chemotherapy. So when the emergency procedure is performed for bowel obstruction, the post-operative mortality is as high as 20%. Favorable prognosis, it has been observed where the treatment-free interval is more than 6 months and there is no ascites. In that case, median survival is around 8 months. Compare with those where progressive disease and ascites is there, where the median survival is hardly 1 month. So finally, whatever is there, the bowel obstruction is associated with poor prognosis, where they have given median survival is only around 6 months. This is regarding this bowel obstruction talk. So these are the questions. Please type in your chat box answers. So a woman who had a treatment for ovarian cancers a few years ago presents with symptoms of bowel obstruction. Which symptom will make you suspect that the bowel obstruction is in the proximal intestines? Yeah, very good. So answer is C. It is a nausea and vomiting. So nausea and vomiting is for proximal, pain and distension for the distal, and absolute constipation is a total obstruction. So answer is C here. Next, a woman who had a treatment for a gynecological cancer is admitted with bowel obstruction. What type of gynecological cancer is mostly associated with bowel obstruction? This is also a very easy question. Yes. So it is the epithelial ovarian cancer. And as a twist, they can ask you in case of radiotherapy, if the patient has previously received radiotherapy, then the most common cancer will be uterine or cervix cancer. Okay, because the cervix is the most common thing to receive the radiotherapy, correct? So if in the question it comes as a history of radiotherapy, then your answer will change to cervical cancer post radiotherapy. Okay. It can be endometrial cancer also, but again in endometrial cancer, radiotherapy is used very less commonly than that of cervical cancer. So this is regarding today's talk. Tomorrow we will discuss another one. So bye for now.
Thank you, ma'am.
Thank you. Bye.